Immunology Insights, Basics and Beyond, Chapter 66, Personalized Medicine in Immunotherapy. Marcello here. Welcome back to Immunology Insights, Basics and Beyond. In our last chapter, we met Shinya Yamanaka and explored how induced pluripotent stem cells opened the door to patient-specific disease models and regenerative therapies, an early glimpse of what personalized biology can look like in practice. Today, we stay firmly in the future-facing part of our journey and ask a simple question with a very complicated answer. How do we move from one-size-fits-all immunotherapy to treatments that are tailored to the biology of each individual patient? We will look at what personalized medicine actually means in the context of immunotherapy, which tools make it possible, and where it is already changing how we treat cancer, autoimmunity, infections, and transplantation. So let's talk science. What do we actually mean by personalized medicine in immunotherapy? Classically, patients with the same diagnosis often receive the same treatment, same drug, same dose, same schedule. Personalized or precision medicine tries to break that pattern by asking, what is special about this patient's disease biology? How is their immune system configured right now? Which target, pathway, or cell type is actually driving pathology in this individual? In immunotherapy, personalization can involve first, choosing whether a patient receives immunotherapy at all versus chemotherapy, target small molecules, or surgery alone. Second, selecting the specific immunotherapy, for example, which checkpoint inhibitor or which CAR target. Third, adjusting dose and sequence based on predicted efficacy and risk of immune-related side effects. And fourth, in some cases, designing therapies from scratch for that patient, such as neoantigen vaccines or individualized TCR-engineered T cells. The goal is simple to state but hard to achieve. Maximize benefit, minimize harm, and avoid giving expensive, potentially toxic immunotherapies to patients who are unlikely to respond. But why does especially immunotherapy need personalization? Well, immunotherapy is powerful but also unpredictable. Two patients with the same cancer type, treated with the same checkpoint inhibitors, can have completely different outcomes. One long-term remission, one rapid progression plus severe immune-related side effects. But why? Because both the tumor and the immune system are highly variable between individuals. First, tumors differ in antigen profile, mutation load, stromal composition, and immune infiltration. Second, patients differ in HLA type, prior infections and vaccinations, microbiome, genetic polymorphisms in immune pathways, and even lifestyle factors. And third, immune activation is a double-edged sword. The same boost that fights a tumor can trigger colitis, myocarditis, or autoimmune endocrinopathies. All of this makes immunotherapy a natural candidate for personalization. Instead of simply asking, what disease is this? We have to ask, what immune disease ecosystem are we treating? Now it's time to build the patient's immune profile. Personalized immunotherapy starts with better measurement. Before we can tailor treatment, we need to understand what we are tailoring it to. A modern immune profile often combines several layers. First, tumor and tissue genomics. So DNA sequencing, the panel, exome or genome reveals driver mutations, mutational burden, and sometimes mutational signatures, for instance, mismatch repair deficiency. Then we have the tumor mutational burden or TMB, which gives a rough estimate of how many potential neoantigens a tumor might present. Cancers with a very high TMB or with microsatellite instability, called MSI high, often respond better to checkpoint blockade because they look more foreign to the immune system. Second layer is the protein expression and surface markers. So immunohistochemistry and flow cytometry show expression levels of key markers, like PD-L1 on tumor or immune cells, HER2 in breast or gastric cancer, or CD19 or BCMA on B-cell malignancies, and so on. Here, HLA typing tells us which peptide MHC complexes a person can present, crucial for TCR-based therapies and neoantigen vaccine design. A third layer is the immune cell composition and state. So hot tumors are infiltrated by activated T cells and other effector cells. Cold tumors lack substantial immune infiltration. There are also immune-excluded tumors where T cells are stuck at the periphery and can't enter. Here, single-cell RNA sequencing, CyTOF, and advanced flow panels can reveal whether T cells are exhausted, so exhibit high PD-1, LAG-3, or TIM3, or whether irregulatory T cells or myeloid-derived suppressor cells dominate, and which cytokines are shaping the microenvironment. And fourth, we have the layer of soluble factors and the microbiome. Serum cytokine levels, autoantibodies, and acute phase reactants provide additional context. The gut microbiome has emerged as a modulator of response to checkpoint inhibitors in the same cancers, for example, with certain bacterial communities associated with better outcome. Taken together, these layers often form a kind of immune fingerprint that can inform which immune therapies make sense and which ones are most likely to fail or cause even harm. Now let's look at personalized immunotherapy in different contexts, starting with cancer. Cancer remains the main arena where personalized immunotherapy has made it into routine clinical decision making. Let's look at a few key areas. First, choosing and tailoring checkpoint blockade. Checkpoint inhibitors like anti-PD-1, anti-PD-L1, and anti-CTLA4 and newer targets can be life-changing, but they don't work for everyone. Biomarkers help here. So, for example, the PD-L1 expression. Many guidelines restrict certain anti-PD-1, PD-L1 therapies to tumors with PD-L1 expression above a defined threshold. Higher PD-L1 doesn't guarantee response, but it shifts the odds. Or MSI high and mismatch repair deficiency. Tumors with defective mismatch repair, for example, some colorectal or endometrial cancers, are highly immunogenic and respond particularly well to PD-1 blockade. Or TMB. In some tumor types, very high mutational load correlates with better checkpoint inhibitor outcomes. These markers help answer questions like, is it reasonable to start with immunotherapy alone? Should we combine the checkpoint blockade with chemotherapy or targeted agents? Or is immunotherapy unlikely to even help here? A second key area is selecting targets for cell therapies. For CAR T cells, CAR NK cells, and TCR T cells, personalization often means antigen choice and risk assessment. In B-cell malignancies, robust CD19 expression across malignant cells and normal B cells makes CD19 an attractive CAR target, with expected B-cell aplasia as an acceptable trade-off. In multiple myeloma, BCMA or the B-cell maturation antigen is a key target because it is highly expressed on malignant plasma cells. And for TCR-T therapies, patients must express both the target antigen, for example NY-ESO-1 or MAGE-A4, and the matching HLE allele. And for TCR-T therapies, patients must express both the target antigen, for example NY-ESO-1 or MAGE-4, and the matching HLA allele. Only a subset will qualify. Here, molecular profiling defines eligibility, expected on-target effects, and off-tumor risks. Very interesting are individualized neoantigen vaccines. At the most personalized end of the spectrum are neoantigen vaccines. The workflow typically involves: first, sequencing the patient's tumor and normal DNA to identify somatic mutations. Second, predicting which mutated peptides are likely to bind to the patient's HLA molecules and be presented on the tumor cells. Third, synthesizing a personalized vaccine as peptides, RNA, or viral vectors, encoding a small menu of neoantigens. And fourth, administering the vaccine, often together with a checkpoint inhibitor, to amplify T-cell responses against these unique targets. This is still an experimental approach, but it beautifully illustrates the concept of using each patient's mutational landscape as the blueprint for therapy. Of course, efficacy and toxicity have always been balanced regardless of the approach. Personalization also matters for safety. Some patients develop severe immune-related adverse events from checkpoint inhibitors, while others tolerate them well. Risk factors may include pre-existing autoantibodies or autoimmune diseases, certain HLA alleles or genetic polymorphisms in immune pathways, or particular patterns in the microbiome. As we learn more, we may be able to stratify patients who can safely receive aggressive combination immunotherapy and who needs a more cautious stepwise approach with close monitoring or prophylactic measures. But personalization goes beyond cancer, for example in autoimmunity, infection and transplantation, as personalized immunotherapy is not limited to oncology only. The same principles apply wherever the immune system is both a problem and a solution. Let's start with autoimmune diseases. In rheumatoid arthritis, psoriasis, inflammatory bowel disease, and multiple sclerosis, we now have a long list of biologics and small molecules. TNF inhibitors, IL-6 and IL-17 blockers, B-cell depleting agents, JAK inhibitors, co-stimulation blockers, and more. However, patients differ in first, the dominant cytokine pathways driving their disease. Second, the presence of specific autoantibodies, for example anti-CCP in rheumatoid arthritis or anti-double-strand DNA antibodies in systemic lupus erythematosus. And third, patients may also differ in comorbidities, for example cardiovascular risks or latent infections that influence safety. Increasingly, clinicians use these features along with pharmacogenetics and real-world data to choose between mechanisms and to sequence therapies over time, rather than using a fixed one-size-fits-all algorithm. Personalization also is interesting in infectious diseases. In several viral infections, immunotherapy decisions may depend on timing and host status. For example, an immunocompromised patient at high risk for RSV or COVID-19 may benefit from prophylactic monoclonal antibodies, whereas an immunocompetent young adult might not. Or in sepsis, where immune profiling can distinguish hyperinflammatory states, where dampening cytokines might actually help, from late immune paralysis, where immune stimulants could be beneficial. These examples are early steps toward tailoring immune modulation to the phase and character of an infection, not just the pathogen name. And last but not least, let's look at personalization in transplantation. Transplantation is essentially immunology in real time. The host immune system must be suppressed enough to prevent rejection, but not so much that infection and malignancy risk explode. So, personalized elements include here first, HLA matching and assessment of donor-specific antibodies prior to transplantation. Second, monitoring of donor-derived cell-free DNA and immune activation markers as early signs of rejection. And third, adjusting immunosuppressive regimens, for example calcineurin inhibitors, mTOR inhibitors, co-stimulation blockers, or biologics, based on rejection risk, infection history, and drug toxicity profiles. Emerging approaches such as regulatory T-cell therapies or tolerogenic dendritic cells aim to induce more durable antigen-specific tolerance, which would be the ultimate personalized outcome, a graft accepted by a re-educated immune system rather than a chronically suppressed one. So, what are the tools enabling personalized immunotherapy? Several technological trends are making all of this feasible. First, high-throughput sequencing and multi-omics. Affordable genome, exome, and RNA sequencing plus epigenetic and proteomic profiling provide rich data on both tumor and immune compartments. Second, single-cell technologies like single-cell RNA-seq, TCR-BCR sequencing, and high-parameter cytometry allow us to map the exact composition and state of immune cells in patients. Third, computational modeling and AI. Machine learning models can integrate genomics, imaging, and clinical data to predict response, toxicity, and optimal combinations far beyond what humans can do unaided. And fourth, digital health. Wearables and remote monitoring can track toxicity, infections, and response dynamics in real time, informing dose adjustments and early interventions. Of course, personalized medicine also comes with challenges, limitations, and ethic questions. As promising as personalized immunotherapy is, it comes with substantial challenges. First, its complexity. Integrating genomic, immunologic, and clinical data into actionable decisions requires infrastructure and expertise that many centers do not yet have. Second, cost and equity. Personalized approaches are often expensive. There is a risk that only certain health systems or patient groups will benefit initially. Third, data privacy. Genomic and immune profiling generates sensitive data that must be protected. And fourth, dynamics. The immune system and tumors evolve. A profile captured at diagnosis may not fully reflect the situation months later, implying a need for repeated sampling and dynamic adaptation. Despite these barriers, the direction of travel is clear: more information, more tailoring, and more nuanced immune interventions. To conclude, personalized medicine in immunotherapy is about moving from "this works on average" to "this makes sense for you." By combining tumor genomics, immune profiling, biomarkers, and computational tools, we can better choose who receives immunotherapy, which mechanisms we target, and how we balance efficacy with safety. We are still at the beginning. Most decisions are guided by a small number of biomarkers: PD-L1, MSI status, certain autoantibodies, rather than the full richness of each patient's immune landscape. But every new dataset and every iteration of clinical practice pushes us closer to truly individualized immune therapy in cancer and far beyond. In our next chapter, we will zoom in on one of the enabling technologies that might make such precision far more practical: nanotechnology in immunotherapy. How nanoscale delivery systems, sensors, and materials can help us target immune pathways more accurately and safely. Before closing, I have a small request. If you enjoyed this episode and want to hear more, please like and subscribe. It's a small step for you, but it helps me a lot. So thank you for listening and see you next time.